Clearly, mobile health and telehealth are not going away. Actually, COVID-19 has even reinforced that these are really helpful and important tools in healthcare delivery.
We've actually just seen an explosion of ideas about how we can treat patients in a way that doesn't require them to come in person and have an appointment with another, a doctor in person.
We're starting with human-centered design, figuring out what is the minimum viable capability we can get out there that's useful to our constituency so they can get their hands on it and start using it and making their lives easier.
Americans are going to be able to get their health records from their providers on an app on their smartphone for free.
We've all got bad handwriting, the ability to get a medical record from one place to the other. Now with electronic health records, of course, that problem doesn't exist anymore.
We are helping the Common Fund launch a new initiative called ABLE, Artificial Intelligence for Biomedical Excellence. This is a $160 million 7-year program that's designed to do a number of things to accelerate biomedical uses of artificial intelligence, create data design centers, develop what we call gold data sets, that is AI-ready data sets, driven not by original hypotheses, but rather from a discovery perspective.
I find the best ideas typically, and I know I'll get in trouble for this, don't come from Washington, D.C. They come from the nurses and the doctors out there in Seattle, Washington. People that are on their feet in the front lines and on the deck plate taking care of patients day by day. I want to hear what their ideas are.
Devices seem to me to be sort of a big category, and from a clinical perspective, there's a lot of different facets that we could be considering as we move forward. There are devices that could, for example, be opioid-sparing devices for pain. And so I think that there's a lot of opportunity to be thinking creatively about how devices might have a clinical impact.
The best data is the one that is available to you. If everybody is building data in their own silos, you have no access to that data, and it is basically defunct at that point.
I like to think data as sort of the red blood cells of an enterprise. They bring oxygen everywhere, yet if they're by themselves, they mean absolutely nothing.
Good morning and welcome to our Digital Health Modernization virtual event. We're really excited to have everybody here and join us this morning. My name is Michael Hoffman. I am the president of Government CIO Media and Research. Government CIO Media and Research is the online destination for thought leadership and research in connection to government IT. So this morning, we put together a great list of speakers spanning across CMS, VA, the Digital Health Agency, and National Institute of Health to really cover some of the topics within digital health that we've been covering here at Government CIO Media and Research. What an interesting time, certainly for our country, as we work through this global pandemic, to cover some of the technologies that exist out there that are helping the different agencies really tackle the issue with the global pandemic, but a wide multitude of issues going forward. We're going to be able to cover such issues such as data sharing in the democratization of public health, as well as mental health, and then modernization of infrastructure. But before we do that, we're going to kick off with an interview with Congressman Michael Burgess. So before I hand it off to our Senior Vice President, Aaron Mirsky, I want to remind audience members and everyone who is joining us that they can take part in this conversation as well. We have the opportunity on social media to share your insights. And also, if you have any questions, you can see the video underneath the video player. There's a box that you can submit those questions. We'll be taking those questions and our editors will be passing them on to our moderators. So without any further ado, I'm going to hand it off to our Government CIO Senior Vice President, Aaron Mirsky, and she'll start our program. Aaron?
Thanks, Michael. Appreciate it. Good morning, everyone. So there are currently 17 positions represented in Congress today. And with healthcare, health-related technologies, and health research innovations being all too relevant right now, bringing that perspective to Capitol Hill is critical to enable health agencies and industries at large to come together, developing and implementing digital health modernization solutions for telehealth and electronic health records and more. Congressman Michael Burgess is one of those physicians and a leader. As the nation combats coronavirus, the Congressman is exploring the promise of health technologies, behavioral health, as well as our economy. I want to welcome you and thank you for being our keynote and guest on this beautiful fall morning when there's quite a bit going on. So Congressman Burgess, to start things off, coronavirus has expedited digital health solutions in many ways and increased adoption of new digital health solutions. This has led to us being in the midst of a true modernization and transformation effort with advances across numerous fronts. What are the key initiatives that you have been focused on?
Well, certainly even predating, and thank you, Erin, for having me on. Thanks to your organization for the work that you do. Even predating the time of the pandemic, this is something that had concerned me. Going back to even after the stimulus bill passed in 2007, which seems like forever ago, or I'm sorry, 2009, which seems like forever ago. And practices were required to update and upgrade. And then some of the feedback I got from medical staff sections at hospitals was, we do this and yet we don't seem to benefit, because if our patient goes to a different hospital in the middle of the night and gets a CAT scan because they came in with the worst headache they've ever had in their life, then I cannot access that data. So the lack of the interoperability or the portability of that data was one of the things that immediately came to me, that if we want this system to work, this is going to have to work. And the term of art is interoperability, and that's really where I've focused a lot of my attention since then. The last bill signed into law by President Barack Obama was Cures for the 21st Century. Cures for the 21st Century contained an entire title within it, which was the interoperability work that we'd been doing in committee literally for 2 or 3 years beforehand. And it was important to, I thought, to get that included and make that part, because you've already referenced the siloing and fragmentation of data between the public and private sectors. It really does not benefit the patient, and really that's where our focus should be. It should be for the benefit of the patient. So the good news is the interoperability title was part of the Cures bill, signed into law, and then we come into a new administration, and Dr. Rucker over at the Office of the National Coordinator for Health Information Technology took that very seriously. He took that task seriously. We had several opportunities to interact with him last Congress when I was subcommittee chair on health in energy and commerce. The rule took a while to get promulgated and took a while to get through Office of Management and the budget, but the good news is it did. And so December of last year, I think it was December of 2018, the last hearing that I chaired as the chairman of the Health Subcommittee, Dr. Rucker came in and talked about the rule that was about to be made public. Then, of course, you get into the time of the pandemic, and things had to be suspended because there were so many strains on practices generally that it was just hard. But I think we're now emerging to a point where, even pre-vaccine, we can now talk about, can we get back to work on what the original vision was in the interoperability title, in the Cures bill, through the rulemaking process, and begin to work with hospitals and doctors and practices and make this work for patients. Because after all, if it doesn't work for patients, then what was the point?
So would you share more with the audience about the vision from both a physician and a legislator? How can we achieve this seamless, secure experience from both a patient perspective and a provider perspective?
Well, as anything else in life, there are opportunities and threats. So some of the opportunities, of course, and it's been my firm belief for some time, and there's not unanimity in this belief, but my belief is that the data should be owned by the patient. It is after all, it's the patient's facts. The patient should be able to take the facts with them wherever they go, whether it's to a new hospital or clinic or doctor, and the next person in line who's going to be asked to render an opinion should have the benefit of all of the data that has been collected. If someone wishes to engage in a wearable device, and I'm a big believer in that, I'm a big believer in monitoring, remote monitoring with wearable devices. I believe that information should belong to the patient. You do have to be careful because there are obviously going to be attempts to extract that data and monetize it and use it for a different purpose. But bottom line is it always has to be done for the benefit of the patient. And one of the things that I think is probably most important is when we get to the application programming interfaces, so that there can be an app on your phone. And it really can, people are familiar with that. The ease of use is well demonstrated in various other sectors. I mean, I pay for my tolls on the tollway on an app with an appropriate interface. I do banking on an app with an appropriate interface. There's no reason why health data cannot be handled in the same way. But as I said, there's opportunities and threats, and one of the threats, of course, is can that data be taken for a purpose that is not for the benefit of the patient, and are there appropriate safeguards? That is something, honestly, that has even going back in the days before the stimulus bill was passed and electronic health records became part of the law, that has been a difficulty that it's hard to get past. I do believe it is possible. I think it is going to require some legislative activity, federal preemption of state laws. But my belief is that the founders, when they wrote the Commerce Clause in the Constitution, they had in mind the benefits that the internet would bring one day. And the Commerce Clause is the perfect application for e-commerce and things that transpire over the internet. So a federal preemption based on constitutional principles laid out in the Commerce Clause, I think makes a lot of sense. On the other hand, there are also safeguards that need to be in place, but there also needs to be certainty for, say, a receiving hospital or a doctor who's participating. There needs to be some certainty in the liability side of things. So that sort of the conflict on the right for people who don't like federal preemption. I try to make the constitutional argument on the left, where people say everyone needs a private right of action to sue anyone for anything at any time, but hold the phone. We really want to be certain that we provide an environment where both the patient and the provider, whether it be a doctor or hospital, feel confident that they will be fairly treated in the exchange if there is any dispute or any difference of opinion that emerges in the future. But that's kind of the moving parts of the existing privacy debate. I do think we're going to get past that. And one of the lessons I've learned when doing a data breach notification bill, when you do this type of legislation, it's also important to be technology neutral, because we, like you're said in your lead-in in the video leading into this segment, Congress doesn't always have the best ideas. We don't have the most recent ideas, and the world changes around us so fast. Witness some of the things that have happened in the time of the pandemic and telemedicine.
Absolutely. These two things working together are a critical part of that. So another area that you've been passionate about is highlighting the needs of behavioral health for our nation's students. And that is at the forefront of many of our minds as we're working and doing our jobs and participating in the economy. Would you share more about the successes and obstacles that you see today in this area?
Well, actually, thank you for that question, because kind of a big win this week with the passage on the floor of the House of a bill by Dr. Drew Ferguson, a member from Georgia. I call him our own Dr. Drew. Called the BIG Act, and this is the Behavioral Interventional Guidelines, based on a program, interestingly, out of Texas Tech, out in Lubbock. I don't want them to think that I think they're out in the sticks, but they are remote, and their population is widely dispersed over a large area. And they recognized, with some difficulties that were being encountered on the behavioral side in schools and some of the high-profile problems that had occurred in schools, that their schools were really at risk because they were so far removed from anyone who could come to help, and they would be far better served with a sort of not a premonition, but to be able to forecast who is likely to be having difficulty, and just as importantly, how could you get them some help before it becomes a difficulty? And I think back to my own time in high school, and we all knew who the troublemakers were. This is perhaps a more refined way of looking at that. But I know Dr. Mitchell out at Texas Tech, and he did this without federal funding. They came in and talked to me about it on several occasions. And it is a great platform that they've used. Dr. Ferguson's big act kind of expands that and provides some federal grants and federal guidelines. So I think that's a positive step. But the whole purpose is to save a school-based behavioral intervention and to act before something becomes a crisis. And I think that's really a goal where we should all be united.
Totally agree. And I think it's great to have leadership in that area. It goes through all of our economy, our children, our service members, our family members. It's something that we're all navigating right now. So thank you for doing that.
Well,
another thing that, go ahead.
Well, and I was just getting, and the fact that so many people now are in a home-based environment. You're working from home, schooling from home, ordering out from home. I mean, everything is families are sequestered in a way that really is unprecedented, and it's led to some. I mean, there's some benefits that people weren't anticipating in the time of the pandemic, but it's also led to a new level of potential problems. And because of that, is there a way to provide a new level of help? And telehealth and telehealth in the behavioral space, I think, is one of the ways that can be accomplished.
Absolutely. And it also leads to innovations and new thought leadership and ideas that we didn't even know existed. So one thing that we're all thinking about is our post-COVID world. And I know as a legislator, you're dealing with the challenges that are at hand, but you're also thinking about our future of our nation. So would you share more about what you're doing now to prepare for the post-COVID new normal and the American economy and the strength of our economy in the future?
So I guess the one message that I always try to impart is that we will get past this. We always do. We've been tested in the past, and we will emerge on the other side in a victorious way over this illness. And the commitment by the agencies and the administration to have 300 million doses of vaccine by January of 2021, program known as Operational Warp Speed. I've been privileged to be briefed on that by a number of the companies that are participating, and it is real. It is happening. The day may well actually happen prior to January 2021, but we stop to think about it. That's an ambitious goal. Literally 1 year from the time the DNA sequence of this novel coronavirus was known, to have 300 doses of a vaccine on the shelf that will provide protection for people. That is a stunning accomplishment. You know, the other side of this too, the fact that the lethality of this virus back in February and March, people were admitted to hospital, people sick enough to come into the ICU, the mortality rate was stunningly high. And it has diminished in a dramatic fashion over just, again, the first 6 months of knowing this virus even existed. So there are a lot of positives as we emerge on the other side. There are a lot of positives we can take from this testing or this challenge that has been before us. And how did our system respond? How did it respond in ways that were helpful to people? How did it respond in ways that were less than helpful? And I do think that I make the statement, any agency where you have to have 256 emergency use authorizations in order to survive the crisis, the problem may not be that you're overregulated. The problem may be the regulations themselves. So I think we as a committee do have an obligation to look at what was necessary to get us through this, and were there some of these emergency use authorizations that really don't need to be redone or don't need to be reinstated. But telemedicine is also part of that experience, and there were waivers that were required over at the Center for Medicare and Medicaid Services. There were reimbursement guidelines that had to be promulgated. All of that expires at the end of the public health emergency. And one of the most frequent questions I get when I talk to groups of doctors is, what's going to happen? Are you going to continue that? And here's the secret's out as far as consumers and patients are concerned. They like it. They like the fact that they don't have to arrange for childcare, take time off from work, pay the exorbitant fee at my parking garage in order to see the doctor to have a relatively simple problem taken on. You mean I can get this handled with a telehealth visit? and the world is not going back to what it was in a year ago when telehealth visits were few and far between. So I do think that telehealth is one of those things that, and we want to be sure it's done right. You want to be sure that there are the appropriate safeguards. What lessons did we learn from the waivers that were put in place and allowed the rapid expansion of this service? And there were also some lessons learned, or I think there are some lessons being learned on the reimbursement side, and we want to be careful that those are done correctly and we don't underprice the service, nor do we've got to protect the taxpayer too, so we don't want to overpay for the service, but getting all of that right is going to be an extremely important part going forward.
Absolutely. So one last question, we just have a few minutes left. What other ways will digital healthcare change post-COVID? Where do you see the biggest changes that industry will face, that the private sector will face for their healthcare?
Well, I think telehealth is, of course, going to be a big part of that. It may, and of course, I've referenced the big bill we did in committee, Cures for the 21st Century. I do think we'll have another version of Cures that is tackled soon, and you want that. You want bills that are forward-looking, that reward innovation. At the same time, I also know that for all the successes we can point to in Cures for the 21st Century, one of the big concerns that has come up is it accessible to people, because this new therapy may be so expensive that it is out of the reach of the people who actually need it. And when I talk to people who are developers in the pharmaceutical and medical device space, one of the things that I stress is I hope you will work with us in the next iteration of the cures for the 21st century, because we may need to think of a different pricing model. A 1970s pricing model may not work for 21st century cures. And I'm thinking things here like, Francis Collins, Dr. Collins at NIH talked about a cure for sickle cell using a CAR T type program. Whoa, that's a big development, and that's going to be expensive and put some strain on state Medicaid programs. How do we properly amortize that if it is a one-time therapy that is going to benefit someone for the rest of their life? You want people to have the accessibility. And then I also look at the question from the other way. What did it cost to do nothing for 40 years? Because unfortunately in sickle cell disease, and we just came through Sickle Cell Awareness Month, there was 40 years of no new therapy being approved by the Food and Drug Administration. So I think we have to take all of those things in context. There was a cost to not doing anything for such a long period of time. There will be a cost to some of these novel therapies. Some things that are only administered one time or over a brief period of time that will be lifelong, it's likely going to require, it's not like developing the last proton pump inhibitor for ulcer disease or the next antiemetic to keep you from being nauseated on a plane trip. These are big changes that people are talking about, life-altering changes for people's benefit. We need to think in different ways about how the compensation for those innovations and those inventions occurs. But it's going to be a great time to practice medicine, and that's what I tell people. This next generation of doctors, they're going to have tools at their disposal no generation of doctors has ever known. And of course, digital health will be a big contributor to that.
Well, I couldn't have ended it more perfectly. That's a beautiful way to say it. Everything is changing around us. The opportunities, the innovations in this space are endless. So thank you for sharing your perspective this morning. I appreciate your time. I think we were able to learn a lot, and it's great to hear how you think about, both the legislative and the health initiatives that are really at the forefront of our minds. So
Great.
Thank you so much.
Thank you, Erin. Thanks for having me on.
I'm going to turn it over to our first panel, led by Jason Chung. He leads our digital and data analytics practice at Government CIO. So enjoy the day, and thank you.
Hello and welcome to the session, Democratizing Public Health Data in the Federal Government. My name is Jason Chung. I am the Director of Data Strategy and Analytics at Government CIO and will be the moderator. In this session, we have invited 3 guests to discuss this topic. We will touch on how agencies are looking to improve the speed, quality, and efficiency of data collection and management for timely responses, while also promoting public trust, data privacy, and secure access to the data. Guest 1. Our first guest is Mr. Ivor D'Souza. Ivor is the Director of Information Systems and Chief Information Officer at the National Library of Medicine at the National Institutes of Health. He oversees the development of NLM's organizational IT strategy and federal IT compliance. He is also the Director of NLM's Office of Computer and Communication Systems, responsible for IT operations and software development programs that serve online content to healthcare professionals, researchers, and patients worldwide. Our second guest is Mr. Kevin Duvall.
Hey, good morning.
Kevin is the HHS Acting Deputy Chief Data Officer. In his current role, he has been heavily involved with the department's planning for the Evidence Act and the development of the HHS Protect COVID-19 data sharing ecosystem. In the past, he has also worked directly for the University of Virginia's Chief Information Officer, driving forward critical actions in audit response, continuity of operations planning, strategic planning, and staff development and learning. Our third guest is Dr. Andy Gettinger. Andy serves as the Chief Clinical Officer for Office of National Coordinator. He is a professor of anesthesiology and was formerly the Chief Medical Information Officer and Associate Dean at Dartmouth. He has extensive experience in the field of health IT. He led the development of an electronic health record EHR system at Dartmouth. So everybody, thank you for joining. Just to start things off, data and universal access to it is recognized as one of the most important starting points to empower data analytics across an organization. For those who are less familiar with data who are joining us in this seminar today, can we talk by addressing what it means to democratize data? So we could start with you, Andy.
Yeah, thank you, Jason. I appreciate the opportunity to join you today. And I'm going to take a little bit of a different tact when it comes to democratizing data. I'm going to talk about first the individual's access to their own data, which has been problematic historically. And by reference, 2 weeks before we ended up in this COVID catastrophe, ONC released regulations that speak to interoperability, but give patients and their designees tremendous access to their protected health information. So that is one aspect of democratization. The second aspect of democratization is we have digitized what formerly was paper records. And with digitalization, there are all kinds of opportunities. The reality, though, is we haven't realized those yet. And so aggregating data from across a large number of patients will be able to give us insight into the care we're providing, what works and what doesn't work. And we can talk a little bit more about that, but I'm going to toss it to my fellow panelists for their perspectives on this.
Ivor, would you like to chime in next?
Absolutely. Thank you, Andy, for that. Being a traditional library, and the National Library of Medicine has been over 175 years old. And so I'm forced to stick to the FAIR principles, findability, accessibility, interoperability, and reusability. Those are really the bloodline. I mean, they are how deep the characteristics that are deeply embedded in how the library functions and makes its service offerings available. I'll talk about three aspects of these things that are really crucial to us. I'd say the first one is reducing the cost of accessing research data, making research data free and publicly available to all parties in a way that would fuel research. And we all know that the government uses taxpayer money to fund a lot of research. We don't see a good reason why that taxpayers have got to pay a second time to get access to that data, either by paying subscription fees to publishers, et cetera. And NIH, for its part, was the first agency in government to have a public access policy, so we're really proud of that. The second aspect, I would say, is to make data easier to understand by lowering the barriers of expertise required to become a domain expert. More often than not, we get so much data. There's volumes and volumes of data coming out continually, and making sense of it is difficult. It's easy for the expert, but not for the newcomer in the research field. If we want to democratize data and make it more widely available to more people and bring more people into the fold, then making it easier is important. And case in point for us is we have the Sequence Read Archive, which is the largest next generation sequence publicly available repository. And it's got raw sequence data. But we also have annotated repositories like the GenBank, where we curate and annotate DNA sequences there. And so we have many examples across our genomic, our literature, information resources, where we help cater to newcomers in the field. And the last one I would talk about is data standards. The National Library of Medicine has been very big in terms of medical vocabularies and the use of standards from data collection to storage to data exchange. While data standards are good for humans to understand and use data over long periods of time, it also has enabled machine-to-machine information exchange. And if you're thinking of scaling democratization beyond just the use of beyond just humans using data, there's nothing better than having machine-to-machine exchange to make it happen. So those are my points. Jason, over to you.
Oh, those are fantastic points. Last but not least, Kevin, we'd love to hear your thoughts.
Yeah, absolutely. Thanks for having me, Jason. So, we're HHS at the department level is really in the process of building up the Office of the Chief Data Officer. So we've been working, we're in the Office of the Chief Information Officer, and one of the things that we came to very early is we really need a vision for what this means. And we can't just say the implementation of the Foundations for Evidence-Based Policymaking Act. It needs to be a little bit more pithy and kind of understand it. So my good colleague, Dr. Kristen Honey, came up with the expression, data of the people, by the people, and for the people. And so in our many programs, in our 84,000 person workforce at HHS, it's really about realizing that vision in lots of areas. So whether it's making information accessible to people so they can make better healthcare decisions, whether it's reading literature or even in the case of COVID-19, making publicly data sets available there from HHS Protect. And then, of course, Ivor can speak to this better than me, but advancing the data needed to support science and research in healthcare. And so we're kind of a mixture of all of this, and the department wants to drive all of this forward under the guise of the Evidence Act and make our data more accessible.
Oh, that's fantastic. So to continue on with what you just said, you've listed a lot of these important factors. What have the challenges been in respect to data democratization in your organization? Could you elaborate that for the audience so they better understand what these challenges are from your perspective?
Yeah, great question, Jason. So how I think about it, and I have a different perspective, we all have kind of, but each operating division has its own kind of culture and policies and approaches to how to share and make data accessible. I think my view on it, and welcome to disagreement, but if we can kind of set more common gauge rails, so the reason that trains can go all throughout the country is because no matter where you go, you kind of have a train that's about this far apart and the wheels are this far apart. We need to set some of those common gauge rails with data sharing, both within HHS and with our federal partners, as well as with the public. The other thing is just kind of fundamental tensions driving behavior. So if you talk to an information security professional, you'll hear things like need to know and least privilege, and those, whether construed correctly or misconstrued, can be kind of in tension with the Foundations for Evidence-Based Policymaking, which is let's share as much data as we can publicly. So how I feel my job kind of plays into all of this is we're not necessarily the ones that are bringing the meal to the situation, but we're setting the table and making sure that the folks in the operating divisions, the folks in the program can do that type of data sharing, and we have kind of a common framework for all of it.
So Andy, just to piggyback of what Kevin just said, I mean, he mentioned some of the cultural as well as the people-related challenges, right, for data democratization. Is there anything that you would like to add to that, or any other perspective from your end for your organization?
Yeah, I'm really going to focus on data that is not HHS data, but is data that feeds the ecosystem. And so what historically has been the problem in that space? So part of the problem is that entities have held on to data because it gives them a competitive advantage, or at least they perceive it gives them competitive advantage. And we invested as a country billions and billions of dollars to try and make data flow and make it interoperable. We're continuing down that road. So how do you do that? So Ivor already mentioned standardization. Clinical data has not been adequately standardized. So we have identified certain standards that all of the electronic health record, health IT developers have to abide by. More importantly, we have made it easy to get data out by specifying the standards and without getting jargony. Open APIs without special effort. And we define the open API without special effort as the latest version of FHIR. That's not F-I-R-E, which you might be thinking about, especially given what's going on out west, but F-H-I-R. And it doesn't matter what the acronym stands for. It is a standard that allows content to move seamlessly. When that content is then available, instead of depending on things like randomized clinical trials that may be multi-centered, 5, 10, 15 entities, maybe reporting on in a big trial, 5,000 to 10,000 patients, we can imagine getting clinical data that pertains to hundreds of thousands of patients or millions of patients, and then inform us in terms of what works, what doesn't work, what's the current therapy. And that, if we had that infrastructure in place now, we would be able to respond to any public health threat much more expeditiously and with much more confidence that we understood how the knowledge is evolving rapidly and changing rapidly. I'm gonna stop there.
Oh, I think this is a fantastic answer. Thank you for shedding light on these challenges. So Ivor, just to piggyback off of all the things that Kevin and Andy have discussed, you're the centralized hub for a lot of the information. And so in terms of what your priorities are for data democratization initiatives, is there anything that you could perhaps elaborate on that might touch on what Andy has, Kevin said, or if not others?
Yeah, absolutely. In fact, when I think about what NLM does for data democratization, there are some default practices that are very much embedded in how we conduct business. One of those is, of course, make sure that all data is publicly free and open. And the other part I would say is we try to make data available in multiple format types. So these are just our default practices. Whether people come by, who swing by our websites, are able to browse it interactively, whether they can download it for their computation in their local spaces, or whether it's for machine-to-machine connectivity through APIs, et cetera. But there are a couple of things I'd like to highlight. One of them was touching on what Andy just talked about. And that is making sure that when we offer data up to individuals, that we try to give them a complete set of data, so that we can support transparency and reproducibility. Sometimes just giving them access to a peer, reviewed paper may not be adequate enough. They may need to see all the data upon which the study or experiment was based, so they can fully understand how to recreate that study if necessary. And so that is a push that we're going after. So that's something I would see develop over time. There's another area that we found to be really useful and important. And that is, we've noticed over time that researchers spend way too much time downloading data, and we find that not all institutions have the capacity or the ability to pay for these big internet plans and these big internet pipes to download data. So we've started moving some of the data to the cloud, where the compute and this data are sitting side by side. It eliminates the need to download large volumes of data. And good examples of that were part of the NIH STRIDES program, where we've moved the sequence read archive, NLM's sequence read archive onto 2 cloud platforms, Amazon's and Google's cloud platforms. And we moved around 36 petabytes of genomic data there. And we've already seen that using tools like, the data query tools that Amazon and Google provide, we're finding organizations collaborating on computational operations that couldn't be done, on local premises. So I'd say these are some of the major priority things that we're seeing that shift the way we're working to further democratize data.
Thank you very much for sharing this, Ivor. Kevin, if you were, since you're the Deputy Chief Data Officer over at HHS, I think you have a more comprehensive view that sits at a level higher. Not saying that NLM's initiatives are very important. I think Ivor gave a great example, but from an overarching HHS view perspective, could you elaborate on the priorities of the agency?
Yeah, so from my vantage point, and Ivor is where the magic happens. That's where the insights come in. So absolutely, he's the person that's really responsible for saving lives, and we're just making sure everyone's working with each other. The big thing for us is really COVID-19. So we're the principal agency responsible for the COVID-19 response, and our data democratization efforts are really heavily focused around making sure the public has access to COVID-19 data. My job at HHS, I'm not on the policy side. I'm on the data and technology side, but we're working really day and night to provide additional data sets and visibility through the HHS Protect program, which is kind of the internal one and state-facing one, and then Protect Public, which is facing the public, the American people. The other piece we're really focused on is enterprise governance. So going back to kind of some of the earlier pieces about making everyone connect and work together, we have so many smart, talented people in this agency. There should be nothing that can stop us from advancing healthcare and doing great work. And so my job and our office's job is really to enable everyone else's success. And I'm a firm believer in servant leadership. My work is to provide the right policies, the right governance heuristics, and really the tools to enable other people's success. And then ultimately mature our kind of data skills and capabilities so we can unlock new insights across all our vast data sets.
Okay, fantastic. Thank you very much for sharing, Kevin. Andy, given that you've mentioned earlier about the data siloing issue and the challenges around that, can you elaborate on your priorities, and also perhaps, and just jumping into another question on COVID, because it was brought up, how COVID has impacted all of the data siloing issues? Do you feel like it instigated a cultural change of some sort and paved the way to make improvements in data democratization across the board? What are your thoughts on that?
So I have, as you might imagine, a number of thoughts, but I'm going to start first with what happened almost overnight when we were all locked down and healthcare had to continue. So the healthcare system, which is notoriously slow to adopt change, changed overnight. So telemedicine came into common use. Dramatic increases. Now, we learned about a lot of challenges, but what enabled that? What enabled that was the flexibility that HHS communicated, both through the Office of Civil Rights and through CMS in terms of some of the reimbursement flexibilities that were allowed. And the garden of flowers of success with telemedicine have bloomed. Some of our other colleagues at HRSA are continuing to make telemedicine resources available, because healthcare, you need a little bit of help. You need the IT guy in your house. If you're a clinician supporting patients, patients need help as well. So that's on a very granular individual level. And I would suggest that we still don't know what kind of clinical encounters are better done with televisits than in-person visits. Certainly there's a convenience factor, but I've been told by some of my colleagues, for the first time, I'm seeing where the patient lives. I'm seeing the context in which they have their illness. The social determinants of healthcare are manifest on those video screens, some of them, not all of them, obviously. But I'm going to switch gears now from the individual care to more systemic care. So some of our data is point in time data. How many ICU beds are occupied? How many shots have been given? How many people have tested positive for COVID, or how many people have died from COVID? Or, as has become clear, how many of the other illnesses have increased during the time that healthcare isn't being provided? The challenge is we need to not get a snapshot in time, but we need to get how things play out over time for an individual patient aggregated. In that space, some of the infrastructure that is not done uniformly across the nation, but done in some leading states very, very effectively, health information exchanges, who've been able to use the data they have, the individual data on patients, and are able to construct insights into what's happening in those communities, not at one point, but over time. That is the kind of powerful data that will enable us the kind of insights that will tell us where we need to go.
Oh, that's fantastic. Kevin, from your perspective, and since the agency is focused on COVID, could you please share some of your perspective on how COVID has impacted democratization efforts?
Yeah, absolutely. So, it's really fundamentally shaped a lot of our activity. So, as the virus and the federal response has evolved, we've also had to change kind of our data release and approaches. As the name suggests, the virus is novel. It's something that's, something we haven't really quite seen before. And so our response on the data side has required us to adapt in kind of real time to the needs of the scientific community. We've changed what data we've collected, and that's a result of better understanding the virus and better understanding kind of the needs of the healthcare community and the scientific community. The one other side of that, so that's one side, which is the healthcare. It's also spawned a whole world of kind of citizen data hacktivists. I've met a whole bunch of people that, frankly, I would have never met before. Who want to really provide tools and visibility and insight into what's going on with COVID-19. And a lot of them are volunteering. And so we've chatted with many of them, and they should be really proud of their work, because it's showing and having people understand what's going on in their community, what's going on in their environment using some of our data. And so it's really been an incredible working relationship. And they've also provided a great sounding board for what data is helpful to the public and what data we should be sharing. So it's been unfortunate kind of circumstances, but these people have really kind of came out of the woodwork and started helping on the data side.
Great, thank you very much. So Ivor, when you're thinking about how COVID has impacted data democratization's efforts, there's also one thing that comes to my mind, which is public trust. If you think it's a key component that's going to spearhead some of these data democratization efforts, how is NLM taking steps to better gain trust from the public with data sharing and reporting? I mean, you hold some key data sets, right, in publications and so forth. It's the backbone of a lot of things that get shared. So I'd love to hear your perspective on that, and if COVID has really altered how you approach any of these issues in any way.
So absolutely, I think public trust is absolutely key to advancing democratization efforts. I'd also say that trust among the partners is very important as well, because there is no one organization that can do it all by themselves. And you can just see here, we have ONC, we have HHS, we have, we partner so well on so many activities, which is what makes it successful. And it's a huge ecosystem of industry and researchers and you name it, the public, the patients. that make this thing very successful. Many of our projects involve participation with agencies within the HHS itself, CMS and ONC and others. So I think that is really key. I think partnerships and building trust across the broad spectrum has been very important. And I think fundamentally the principles that we utilize to make information free and widely available is another aspect that really generates and it brings in trust from partners, because they see that as being a very laudable goal. And we also have feedback mechanisms to inform all the projects and products and offerings we have. So we partner with industry, we partner with all our stakeholders to take in feedback and to receive the feedback that we need to improve our products and services in a way that would benefit our customer base. We also have a consortium that we lead called the National Network of Libraries of Medicine, which is a very interesting consortium. It's made up of over 8,000 members, health science libraries, public libraries, community-based organizations. And that gives us reach into the community, reach across the country, where we're able to then not only get feedback to help improve our services, we're able to drive health-related initiatives that benefit the population at large.
Thank you very much. For the sake of time, there's only a couple of minutes. I know there's two responses that we could get. I know this is a burning topic, and I know, Andy, you really wanted to touch on this. And I'm giving the floor to you, but Kevin, thank you for your understanding. This is going to be the last question, unfortunately. So Andy, please, if you want to elaborate on your views on public trust as being on how that has changed as a result of all of the COVID efforts, and as well as how that is spearheading the data democratization efforts. We'd love to hear your thoughts on that.
Thanks, Jason. I would have happily passed this over to Kevin, but I'm also very happy to speak about it. When we talk about information in response to something as overwhelming and threatening in so many spheres as this pandemic is, we depend on not only the knowledge we have, but the knowledge that we have to derive very, very quickly. And we need to make sure that that knowledge, new knowledge, is trusted broadly through the healthcare ecosystem. So clinicians, one, need to learn about it because it's new. It wasn't taught in medical school if you're a physician, it wasn't taught in nursing school if you're a nurse. But then those, to be implemented into care, patients need to have trust as well. And you can think about all those things where people are communicating anxiety about what they should do, what advice they should take. So this whole space of science, represented by EVOR and the National Institutes of Health and National Library of Medicine, HHS broadly, trying to bring science through AHRQ, some of our other sister agencies. We need to believe that the science is what's driving the policy. And I'll stop there. As you know, I can go on a little bit longer.
Thank you very much, Andy. I appreciate it. So Ivor, Kevin, and Andrew, on behalf of Government CIO, I want to say that it was an honor to have such highly esteemed guests participate in this event. GCIO, the audience, and I really appreciate your sharing your time, insights, and thought leadership on the topic of data democratization. This concludes the session on data democratization, public health data in the federal government. We would now like to transition to the next session, which is transforming mental health care services with technology, and it will be moderated by our Vice President, Orjugo Horehan. Thank you very much, everybody.
Thank you.
Welcome. My name is Orjugo Horehan, and joining me today, three incredible panelists to speak about transforming mental health care with technology. First, Dr. Simon Pincus. Simon is the branch chief for the Connected Health branch at the Clinical Support Division of DHA, Defense Health Agency. The Connected Health branch deals with leveraging technology to optimize healthcare and healthcare outcomes across DoD. He retired from the US Army as Medical Corps officer after 25 years and has had behavioral health as a very visible thread throughout his career, both as a serviceman and now as a civilian. Hi, Simon. Can you hear me, Simon? Okay. We might be having some issues there. I'm going to keep moving. Next, we have Paulo Del Becchio. Paulo is the director of the Office of Management Technology and Operations at SAMHSA, Substance Abuse and Mental Health Administration of HHS. Paulo has had, vast experience on the mission side at SAMHSA, looking after our country's very pertinent mental health challenges, from child mental health to homelessness to suicide prevention. Paulo is a self-confessed mental health consumer himself and has been in this battle to tackle mental health in this country for more than 40 years. Hi, Paulo.
Morning.
How are you doing?
I'm doing great, thank you.
Relief, some audio. Okay, great. Jose, next, Jose Ramos, bringing a needs and mission perspective to this discussion. Thank you for being here, Jose. Jose is the Wounded Warrior Project's Government and Community Relations Vice President. Wounded Warrior Project is a vet service organization that services wounded veterans. The COVID pandemic, we've seen increased adverse mental health incidents. CDC is showing that between April and June from 2020, looking at the numbers for anxiety and depression, our numbers are up in comparison to 2019. Paulo, I'll start with you. What would you say the impact of COVID has been on mental health and substance abuse? And how is it changing how you deliver mental health services in terms of technology?
Great, thank you, Ojigo. We have the COVID pandemic, but there's also a corresponding mental health pandemic that we really are experiencing in this country and impacting, frankly, all of us. CDC data, as you said, says up to half of all Americans are experiencing significant mental health disorders right now. We're seeing reports of increase of alcohol and substance use at the same time. We're seeing concerns about increases in the rates of deaths by suicide, as well as overdoses as well. So issues of anxiety, depression are ones that many Americans are experiencing. Certainly social isolation is a significant factor that's contributing to that. And in addition to this incredible demand, I just saw a study last week that said that the number of Google searches for depression and anxiety have spiked since the COVID pandemic has started. So people are turning to the internet to find help. And frankly, for mental health care and addictions care, it's completely turned the delivery of care on its head. In that prior to COVID, data was showing that about only 2% of all mental health treatment was provided online. Now we're getting to an age of digital first, frankly, that people have to, because there's with social distancing, have to go online for a series of steps in order to get support. We're seeing efforts such as 80% of providers now providing a majority of their services online, where that was completely different than the past. Particular states like Minnesota, 16-fold increase in telehealth just since the COVID pandemic has started. Not only for particular treatment, but you consider things like support groups, AA and the like. And now people are having to go online in order to get the services. So for mental health care and addictions treatment care, it's completely flipped how we provided services. And, you know, there's a huge need for both the kind of care and services we're providing. And, you know, technology is stepping up to help provide that kind of support.
So just a follow-up question before we come to you, Jose. What specific resources or tools what is SAMHSA looking at right now that has changed in the last several months? I think that's a really impactful piece of information.
Absolutely. I think, you know, one of the things that probably the most important resource that we offer is the National Suicide Prevention Lifeline.
Okay.
And here, let me give you that number. 1-800-273-TALK. And that's an extensive telephony system, has text capacity, connected to crisis centers across the nation, available 24/7 with trained counselors. We respond to over 2 million calls a year from people in crisis. And again, the numbers have increased since COVID. And we just ended National Suicide Prevention Month in September. I'll make a note of that as well. One of the exciting things that we're doing with that particular system is we've been working with the Federal Communications Commission on establishing a 3-digit number for the Lifeline. So starting next year, we'll be moving to 988 for National Suicide Prevention Hotline. This is also something that we partner with our colleagues at the Veterans Administration in terms of particularly you hit 1 and you get connected particularly for VA services for people in suicide who are suicidal. Second resource I would cite here is our Behavioral Health Treatment Services Locator, Findtreatment.gov. This is one that we just upgraded this year, where people can go online, put in your zip code, searchable by zip code, types of treatment, payment options, age, language that you speak, for vets, LGBT, deaf and hard of hearing, and others, and come and get resources that are local to you, where you can get the help that you need. So those are 2 critical resources technology-wise that we've launched here recently.
That's incredible. So I'm going to pivot to you, Jose. Wounded Warrior Project is the biggest investor in mental health programming for veterans. Has COVID impacted your mental health programming specifically and legislation that affects outcomes for veterans?
Yeah, so first of all, I do want to say thank you to you, Ojigo, and to Government CIO for the amazing work you guys do, quite frankly, with the VA and for hosting this conversation. As you know, Wounded Warrior Project, we meet the mission to honor and empower wounded, ill, and injured veterans by providing mental health support, clinical care, treatment, and not only that, but employment counseling, physical health and wellness, guidance to benefits, peer connections, and obviously helping family members, caregivers, and survivors, right? And these programs really do serve as a connection point, and they're typically done in person, right? And as you indicated, COVID-19 has obviously changed how we all collectively interact with each other, and particularly how Wounded Warrior Project engages with the warriors we serve, right? Specific to mental health programming, we at Wounded Warrior host we have a host of different programs aimed at increasing resiliency and decreasing PTSD symptomology that we refer to as our mental health continuum of care, right? This continuum includes what we call Wounded Warrior Project Talk, a series of conversations that an individual can have with a Wounded Warrior representative, right? Our partnerships with 4 renowned universities, Rush, Emory, UCLA, Mass General, as part of the Wounded Warrior Care Network, eHome, as well as other clinical intervention options. And a lot of these, quite frankly, require a face-to-face interaction, which has come to a stop, right? And so at Wounded Warrior Project, what we have been able to do is pivot quickly in an attempt to meet those increased needs through the use of existing or pre-existing relationships and strategies, right? So for instance, our program implementation, we developed a program implementation of virtual engagement, right? which means that, for example, Project Odyssey, which is an in-person event, turned into a virtual event for us, right? So we're relying heavily on, IT and kind of virtual platforms to engage with warriors. Additionally, prior to COVID-19, we had partnerships and funded organizations to provide those virtual mental health services. And as I indicated, originally used for veterans who may have been geographically isolated, right? So you're thinking of your rural veterans who don't necessarily have that instant access to some of our programs. So quite frankly, to other programs, we realized that the need is not just for rural Americans anymore. It's really for everybody. Everybody to some degree became a rural American, right? Because we're all isolated to some degree. So we were able to increase the bandwidth and to increase the use of telehealth during these times, which have challenged some restrictions, right? And we've also learned a little bit about the increase of telehealth, that it really requires additional conversations, because with the increase of access to clinicians over telehealth, there are still other restrictions, such as prescription restrictions on telehealth and so forth, right? So we do find that it's important to not only have this discussion now, but to continue to have these discussions as we move forward. Because as indicated by the previous caller, this is quite frankly something that we foresee growing in the future. Once we get back to face-to-face, we will grow to continue to increase the use of virtual platforms. As it relates to legislation, I'm glad, we mentioned the 988 number, which is the National Suicide Hotline Designation Act, which is what was changed, right? Or, we have been at the forefront of two major legislations focused on mental health during this time. One is the National Suicide Hotline, which is, as indicated before, a bill to ensure that the new 988 number is properly funded, right? And that it is an easy resource for folks who are dealing with mental health issues. And then we spent a lot of time, quite frankly, it was one of our legislative priorities, focusing on the Commander John Scott Hannon Veteran Mental Health Care Improvement Act, right? This was a bill, quite frankly, that helps increase existing VA mental health programming. Additionally, it really does focus on growing and becoming more comfortable with telehealth care and increasing accessibility through more convenient locations. So, I again appreciate you asking those questions.
No trouble. Hey, let me just check in. Simon, can you hear me?
Yes, I can hear you. I was having some challenges at the beginning, but I can hear you.
Oh, yay. All right. So I'm going to come to you. We were going to start. We had a little bit of a chat about COVID. You couldn't hear us, but the long and short of it is we all know COVID has changed the way we live and work. Connected health is focused on using technology, whether it's through telehealth or augmented reality, to deliver health solutions to our nation's service members and their families. How would you say the pandemic has impacted your virtual health strategy?
So first of all, yes, I am with Connected Health, which is part of the Defense Health Agency, which is the overarching body that is going to be working with all of the 3 military services to provide their health care. So yes, as the other two esteemed colleagues were talking about, COVID really caused us to pivot from where we were at now. The military has long leveraged virtual health because we have service members that are deployed or downrange. And in behavioral health has been one of those significant entities, whether it be seeing a service member to base camp, where there isn't a behavioral health provider, or whether it be we have 3 telebehavioral health hubs that are located, one in Europe, one in the United States, and then one in Hawaii, that cover the globe. So when COVID hit, which is sort of pivoting back to what you asked, we went from maybe 5 or 10% of telehealth visits to up to 80% in response. And fortunately, our infrastructure allowed us to do that. And of course, that's really important for both the service members or beneficiaries, could be family members or even veterans, to be able to stay at home and not have to be exposed potentially to virus, but also the providers And this was the real change. The providers started also delivering care from their homes to the beneficiary home. And we even have now providers looking, and I think the VA has been doing this for a while, where we have a provider who may actually just do 100% telebehavioral health to our beneficiaries. The other pivot that we did was we had some programs already in place for mobile and web applications. So we had some applications that you could put on your smartphone to help with dealing with stress. And one of the ones that we pivoted then was we noticed that providers were under a lot of stress because they're also subject in very similar way to the same things that our patients are subject to in terms of the threat of COVID-19. So we created a provider resilience toolkit, which is a mobile application, and it's a suite of tools that allows for providers to do things like meditation or breathing and similar kinds of things. And we saw a 350% increase in the use of that particular tool by providers at the beginning.
That's incredible.
And the other is we were already in the process, the DHA, the Defense Health Agency, was already in the process of developing a tool or what we call a progressive web application for infectious disease. And because of COVID, we accelerated the development of that progressive web application to include all of the guidance that providers might need for COVID-19. And what's really cool about the progressive web application is that unlike something that you would download in an app store, it can be updated in real time. And so as the new guidance comes up, it takes about 2 weeks to put that information in there. And it doesn't just deal with COVID-19, it deals with all infectious diseases. And right now, when we look at how we prescribe medications for infectious disease, we have to do it based on their location, on which antibiotics work well where. So again, that's not quite mental health, but it relates to our COVID-19 response. And the last is we have a virtual health hope box, which is really what we took a lot of our provider resilience toolkit from. And it really is a way for patients to interact with mobile apps to manage their stress and anxiety, and also create safety plans. And there's things that they would tell themselves to do if they were overstressed, because when you're really stressed, you tend to get tunnel vision. And so they could actually pre-plan how they might respond or who they might call. And that's related to then the suicide hotline, which is really helping patients have more tools to be resilient. Thank you.
So one of the things that I think is a very visible thread on this in terms of mental health and just generally, I think whatever technology that we're looking at, we need to be thinking about scalable always, because anyone who had technology that couldn't scale was basically stopped in their tracks when COVID hit. So speaking of technology, I'm going to come to you, Paulo. 2 words that come to mind always when I think about health in general, but mental health specifically: privacy and evidence. So question for you, how is SAMHSA dealing with privacy and evidence right now, particularly in this era where I'm sure a lot of technology is coming at you to implement?
Well, let me start particularly the note about in the private sector, in that in many ways, in terms of mental health, digital technologies, it's still pretty much a providable Wild West out there. Consider this: over 15,000 mental health applications available now on various platforms, and the growth continues. 2019 alone, over $637 million invested by venture capitalists in over 60 startups. And in just the first half of this year, close to that number already. So the growth in terms of mental health startups is huge, and all these investments that we're seeing. Question really is, do they work? And what are the privacy issues as it relates to them? We're seeing marketing by celebrities from everyone from John Legend to Michael Phelps and many more. Everyone's kind of jumping on, but again, are these really helpful? Look to a study last month in journal Start about the largest mindful meditation application out there. 65 million members using this application. They claim a 16% increase in happiness in just 10 days. And yet, what is the science of this? When their biggest concerns being, how large of the studies are we doing to determine the effectiveness? Most studies that are being done thus far in mental health IT are very small. And is it really also the placebo effect at play here as well? We really need a lot more research to identify this. One of the exciting things most recently is the FDA, just in June, permitted the marketing of the first game-based digital therapeutic for ADHD. This one did include a large-scale random controlled trial of 600 children. First game around mental health treatment online to date. We also know things like digital cognitive behavioral therapy has a great evidence base. There's a lot of models out there online for that. We also have to think, look at other models like in Germany this year, passing the Germany Digital Healthcare Act, first national framework for the reimbursement, prescription, and regulation of digital health acts. We have a long way to go here in the US, but that's something to look at. American Psychiatric Association has developed an app advisor for psychiatrists. We're working now with the Center for Technology and Behavioral Health at Dartmouth to conduct various studies and research looking at the evidence on this. When it comes to privacy, 2 days ago, just one example, ransomware hack of one healthcare provider in behavioral health, impacting 328 behavioral health facilities across the country. Also note this is National Cyber Security Awareness Month. We just started. We got that 44% of healthcare organizations don't meet national cyber standards. And yet with these applications, only 19, recent study, 19 of 24 of the most popular health apps on Google Play transmitted user data to at least one third-party recipient. Nether found that 33 of the 36 top-ranked depression and smoking cessation apps sent user data to a third party, and yet in vast majority of this didn't disclose this information to the consumers. So we have a lot more to do when it comes to privacy on these kind of applications in mental health technology, and really the need for simple and plain language for consumers so we understand what is in fact being disclosed.
So I'm conscious that we have not very long to go, and I really want to touch on this artificial intelligence subject. So I'm going to start with you, Simon, and I'm trying to get to everyone on this question. So artificial intelligence and advanced predictive analytics have been really topical when it comes to mental health. So looking at patterns of behavior and connecting them and saying, okay, this person predicting behaviors that lead to adverse mental health outcomes. Is this a viable option that DHA is looking at or implementing currently?
So currently what we have is a behavioral health data portal, which is patient-entered data, where providers can see what patients, their depression scales or PTSD scales or anxiety scales might be in real time. So when we look at artificial intelligence, what you're looking at there is sort of getting huge data sets that then could be looked at for how they translate to a given population. And then you want to take that to predictive analytics. How might that apply to this particular patient?
Oh, yes.
So we're doing really well with looking at populations right now with those tools. We're not there yet where we're able to take all of that data and put it in one location to really do the kind of predictive analytics that you're talking about. But there are definitely efforts, and again, this is a little bit outside of my experience, but there are definitely efforts to put all of that data into one data warehouse where we can start that conversation. So I think that answers your question in your rush for time. So I'll let the others talk.
So I'll come to you next, Jose. What do you think? Is this a viable, from your perspective as a wounded Navy corpsman, is this a viable option to help in the fight against mental health adverse incidents, particularly suicide prevention?
Yeah, I mean, that's a great question. And the answer, quite frankly, is yes, right? We're really pleased that AI and predictive analytics really is part of the Prevents Roadmap, right? A broader national suicide prevention campaign, which does emphasize the need to improve the range of interventions available by expanding research on risk profiles and identifying veterans at risk, right? We're also, obviously excited what the new electronic health records can bring, right? I think that the intent here is to develop a health record that will follow a service member into transitioning into the veteran population, and the ability to include AI or predictive analytics within the service records, I think, are crucial in identifying those at risk during transition, because we obviously see a high risk of suicide in transition, particularly the first year of transition. And then obviously the legislation within the S-785, the Commander John Scott Hannon bill I discussed earlier, talks or encourages some reporting requirements as it relates to the VA's REACH vet program, right? Which I think is a really interesting and phenomenal program. If you're not familiar with it, it's the Recovery Engagement and Coordination for Health Veterans Enhancement Treatment. And it's been around since 2017, and a lot of it is really trying to identify veterans who may be clinically benefiting from enhanced care and outreach and assessments of risk. And I think that they have the capability to use AI analytics to help identify those at higher risks.
That's awesome. I think that's really great progress. And I think the future of applying artificial intelligence within mental health is very encouraging. Any last remarks on this, Paulo? Final remarks?
It's really very quick. I'll say, it's exploding, the kind of AI that's being applied in mental health, from digital phenotyping to machine learning, natural language processing. Very promising, exciting. Also, we have to have concerns too, though. For ethical issues, again, privacy, evidence. We have a lot more work to do.
And hopefully this is a discussion that we will continue to explore here with government CIO media and research. So firstly, I want to say thank you to three of you for being here, for giving us your time, lending us your knowledge and expertise on this subject. This has been really riveting for me, and just opening my eyes to what's going on in your different agencies. Next is going to be updating legacy systems with my colleague, Andrew Underhill. So thank you all, and see you next time.
Hey, good morning, everybody. My name's Andrew Underhill. I'm CTO at Government CIO, and I'm going to be hosting this panel. Today, as mentioned, we're going to be talking about updating legacy systems for public health responses. This need for investment in modern healthcare infrastructure is very timely, obviously due to the pandemic that's currently here. We're going to hear from federal health officials on how agencies are working with agility to update their systems and process to better serve the public. So with that goal in mind, let me introduce Colonel Bobby Saxon, who's the Deputy CIO of CMS. Good morning, Bobby. And from USDS, we have Jess Whedon. Good morning to you.
Good morning.
So maybe I can start directing my first question to yourself, Bobby. Could you tell us a little bit about your responsibility, CMS, and CMS's mission, just to get us started.
Yeah, good afternoon, Andrew and Jess, and good morning to those who may be out on the West Coast who are watching this session as we speak now. I am the Deputy Director for Office of Information Technology at CMS. I've been at CMS for about 4 years, and my role at CMS with OIT is really to assist the CIO in implementing his priorities across the organization and to be very focused on our customer experience. And our customers are both inside and outside of a CMS. CMS is a large organization, and we have about 25 subcomponents. And each one of those components typically has their own challenges and issues and capabilities that they need to deliver. And many times that means they are building their own systems. And OIT is in support of those systems. We do indeed build and maintain some of those systems, but many times we're offering up services such as security to assist them and take that kind of enterprise load off of them so they can stay focused on their mission.
Thank you, Bobby. Now, Jess, I'm really excited to have you here. I'm a bit of an advocate of change, evangelist of doing things differently. So for those who don't know USDS, US Digital Services, many people think of you as an organization that does things a little differently to the rest of government. From your perspective, how would you describe this difference, and how is that really making meaningful change on a day-to-day basis at CMS?
Yeah, so the vast majority of USDSers come from private sector. So we kind of have a different mindset, a different background, exposure to a lot of, best practices from private industry. And we purposely bring that into government. And I like to kind of say that it creates some healthy tension. For example, I've noticed that government can be very risk adverse, and rightfully so. They're stewards of, citizens' data and, delivering services that are crucial to people's lives. But that can also slow things down when you have a more cautious attitude. So oftentimes USDS, pushes to go a bit faster. I'm definitely not an advocate of the move fast and break things mentality when we're talking about these crucial services. But, personally, I come from, maybe an excess of empathy where when I see things that aren't being delivered in the best way that I know they can be, I want to make that change as fast as possible. So I kind of say if both my federal partners and I are uncomfortable with the speed of change, then we're probably in a good place. So yeah, that's just one example of how I think we push for different mindsets.
And awesome. Jess has done a great job of doing that. We have developed a really great partnership between OIT and USDS, and especially Jess and myself. I feel like the mindset is the right mindset for USDS. And if USDS had come along 20 or 30 years earlier, I might have been an early USDSer because I share that mentality with Jess and with USDS.
Yeah, and there's a ton of people in government who are, I think, thirsty for this change. And so we've built up great relationships over the course of our existence this past 6 years. USDS is 6 years old now, which really is what makes this change possible.
Yeah, I think it's interesting. There are some impediments to change for a long time due to the procedural nature of designing software and implementing systems in government, right? Those barriers have really been broken down today, and I think your organization can take a lot of credit for doing that. So, I was going to ask you what does IT modernization and digital health modernization really mean to you, Bobby? I know we've had some conversations over the last week or so on what IT modernization really is, and I think it's intriguing, and I'd love you to share that with us.
Well, sorry about that, Andrew. I think that one of the points that Jess made about risk really plays into IT modernization. And when you really get down to just the pure black and white bits and bytes kind of approach on IT modernization, very few people are against modernization. it is the risk involved with modernization that many times impacts culture, that therefore impacts either the desire to do modernization, or B, the desire to do it more rapidly. And I have always thought of modernization more as a mindset and not a project, and that modernization efforts must become who we are, not just a continuous set of projects. That we're always looking for opportunities to serve our stakeholders better in a faster, more efficient, less costly way, and not do it for the sake of IT, but do it for the sake of the delivery on the mission.
Yeah, absolutely. I think it's a mindset and it's a process. You know, I think in some ways, maybe delivering modern software is kind of the easiest part. Not to say it's easy, but focusing on what that technology enables and then restructuring the way we work so that we are focused on how to improve, for example, the provider beneficiary experience. Because that technology enables, you know, a real-time view into the data so that we can offer coordinated care, so that we can allow, you know, rural providers better insight into their cash flow from Medicare so that they can stay afloat. That's really what we're doing, and making sure that people are focusing on that North Star is key to the modernization process.
Yeah, it's interesting to me that the thing that excites me is that, you know, we're really moving the use of government applications into the hands of the citizens now. You know, right? It's, you know, we're not making phone calls to call centers any longer and somebody else is using the apps. You know, the apps are being used by phones, by people on phones and websites, etc., and putting in the hands to the people that really matter. So, you know, what is the most exciting story that you can share with us? You know, not only at CMS, but maybe in the last 3 years you've been with USDS.
Well, Andrew, there's a lot of exciting stories at CMS when it comes to modernization. I happen to have a meeting just this morning with some folks from Healthcare.gov. As many folks on this meeting know, we moved Healthcare.gov to the cloud in 2018, wrapped it up the beginning of 2019. And we saw that as the beginning of the modernization journey for Healthcare.gov. And now we're 18 months past that March delivery to the cloud. And the briefing I received this morning was talking about some of the many positives that we are already seeing as a result of that move to the cloud. And one of the ones that a lot of people like to talk about is cost savings. And I've heard so many times, don't move to the cloud if you're trying to save money, because you can't save money if you move to the cloud. But there's a genuine success story about Healthcare.gov's move to the cloud and moving out of data centers that did not give us the kind of flexibility that we needed into a much more agile and nimble setting in the cloud. And one thing that we are going to do for this upcoming open enrollment, which is a month from today, based on some interaction with USDS, as a matter of fact, is prepare ourselves to be ready for a surge of new stakeholders, new customers coming to the website because of what's happened over the last 6 months with the pandemic. In an old environment, it would have been almost nearly impossible to do the kind of expansion to improve performance and stability. But in the cloud, we have upsized our capability, or we will have it upsized our capability to 2.5 times normal because we're in the cloud. And so that's a huge story about the potential impact of the pandemic and the ability to do something so bold because of the modernization effort. And that's a story we want to share not only throughout CMS, but across the federal government, that sometimes it may be difficult. It may even be something you don't want to do, to move to the cloud, because you're in a data center and you're comfortable and the contract is all in place. But we don't know when the next thing's going to pop up that's going to require us to do something entirely out of the norm in order to be prepared for the next big thing. And that beginning step towards modernization of simply moving to the cloud positioned us to be even more ready for the open enrollment, which will come up a month from today.
Yeah, I think resiliency and ability to adapt to unpredicted things is a huge part of modernization. On the project I'm supporting, which is modernizing the claims processing systems, one of the first things we worked on was converting what's called a pricer. It's just a small piece of software that calculates what a claim should be paid. And previously, when it was on the mainframe, it had to go through this huge 9-month-long change management process to make sure that it didn't break anything. And CMS has figured out how to make that work. But when things go wrong, say there's a bug or there's a last-minute change to the policy, that often would mean that you'd have to suspend the claim, which means that we're delaying the payment that's going out to providers to make sure that there's time to implement that change. When you move to a more modern world in cloud with our Java-based pricers, you're able to make that change much faster. And so you're not delaying payment to providers, and you're not dealing with that increased call volume about why haven't I been paid. So it's not just about the cost of the IT itself, but also all of the service and support around it. No one has to work over the holidays now to make sure that gets deployed. There's kind of this ripple effect as well.
So have you had to implement any changes in response to the uptick in telehealthcare events on the CMS side? In terms of the payment processing, has that speeded up? Can you talk about that?
So yeah, that's something we're definitely driving towards. Whether it's telehealthcare or new billing codes that need to be added around COVID. When you have this modern system, you can implement those changes much faster, rely less on manual labor, and provide greater visibility and closer to real-time data if that is all available in the cloud in a way that it takes much longer right now in the mainframe.
Yeah, I think, on top of all the isolation and job losses and, people losing loved ones, that's really important to be able to, react quickly. Sure, I appreciate that for sure. So Bobby, what is your vision for digital health modernization or, Medicare payment system reform, legacy systems upgrade at CMS?
Well, to try to oversimplify it, it's basically a vision where data flows freely, securely between the payers, the providers, and the patients. Anyone who needs access to data has access to data. They're able to utilize that data in real time or near real time. And our systems modernization is not just talking about moving from mainframes to the cloud, but how can we use technology now to empower our stakeholders, whether they are payers, providers, or patients, in a different way than they've been empowered previously. I think you see what Jess was just talking about, the speed of change and the access to information because of, in our case, the cloud, but it's really a new way of thinking. But that delivery model that says we were going to deliver with a more of a focus on interoperability and patient access allows us then to, that's the kind of vision I believe that many folks inside of CMS want to see, and that Jess and I are working closely, especially with Medicare payment systems modernization and Medicare modernization, to try to make a reality over the next few years.
Yeah, thank you. Jess, one of the things I've noticed USDS is very good at is that user-centered design and involvement. Bringing in elements of behavioral science upfront and early to make sure that we're delivering the right feature set for the users or beneficiaries of services. How is USDS supporting the vision through methods such as user-centered design and behavioral science?
Yeah, so I'm actually a human-centered designer by training. And so this is definitely an issue that's near and dear to my heart. And I think, I've seen greater adoption at CMS and across government in general for those directly public-facing services, which is huge. I'm very excited to see that. Like, someone should be able to navigate services, but I'm also advocating to bring it to these back-end kind of IT modernization projects. And I'm very intentional when I say human-centered design rather than user-centered design, because there's humans all throughout this. There's humans that are supporting these systems. There are humans that are using these systems. There's humans that are using data from these systems that enter other systems. And then there's policymakers that are getting their policy implemented through these systems. And all of these people matter, and they all need to have feedback on, are they achieving the goal that they intended to achieve? And so, I do user research with all of these people and work to actively kind of diagram and show out and lead conversations to talk about how the decisions we're making about how to structure these systems have intended and potentially unintended consequences for how the system and the processes operate. It's a much larger ecosystem. And yeah, human-centered design is a way that allows you to understand those needs and those motivations so that you can have those conversations, as you said, a vision and a strategy for how to move forward.
Yeah, thank you.
And Andrew, if I can add to that, as an IT person by trade, I kind of see human-centered design as people skills for geeks in some ways. And an oversimplification there is many times IT people see the delivery of a capability in a very black and white way. And the end users, those stakeholders, they see it more in vivid color. And so if you say, give me X, and then the IT people give you X, they're like, well, I delivered what you said. And the vivid color team members say, well, I really kind of thought it was more like this. And where human-centered design does is it allows us to really connect those people in a different way, so that you're trying to put IT folks, and as Jess mentioned, all through the whole process, in other people's shoes, so they can kind of see and then act and build capabilities and deliver capabilities that are simpler to use. I always said about my mom, when we were delivering code over at healthcare.gov and previously when I was at the Army, is, will my mother understand this? Will my mother be able to do this? Because if she can't, we have overly complicated that delivery, and that really is kind of a real basic simplified approach to what the huge value of human-centered design.
Yeah, I think a huge part of that is showing the greater context that people exist within. I think there's a tendency when you're working on a project, that's really all you're thinking about. But you need to keep in mind that the people that are using your systems are probably coming to it in the midst of a whole other life, especially now, when there's a lot going on, a lot of stress. You can't expect them to focus solely on, what you're doing and expect them to grab, fully understand maybe some of the more complex things. They might be switching between 10 different systems to do their job. And that's a very different experience than just sitting at one system for, hours on end. And the more you can fully flesh out people as three-dimensional, the better system you're going to design.
Yeah, I think that's very true. I was once in a seminar where they were talking about bringing in Disney theme park designers to redesign a workspace so that people could work more effectively. And IT was a big part of that, but who would have thought bringing in Disney as a way to improve productivity and whatnot. Awesome. So can you share some of your modernization success stories with us?
Well, I'll expand a little bit on the healthcare.gov modernization. And that's a journey. It is not a completed journey, but it is definitely a journey that's underway, and a mindset change at healthcare.gov. But being bold enough to take the risk and overcome the risk and mitigate the risk of moving from data centers to the cloud empowered the organization to start thinking about many other ways of modernization. One of those is software licensing. You don't think about that, but if you're inside of the government, you're dealing with licenses, and that is a constant nightmare of trying to keep up with your licenses and manage those and know which versions you're using and so on. And one of the reasons that occurred at healthcare.gov is because it was a highly distributed organization, like most organizations inside of CMS. And so those licenses were commonly put in contracts for our developers, put in contracts for our data centers, put in contracts for other vendor partners that we were utilizing. And so we quickly lost a good feel for what the reality was. But as a part of that modernization, stripped out all of that, put that all under a simple little small office, and now manage that. And so if you want to know every dollar and every penny and where we're spending those licenses, what versions of licenses we have, if we're utilizing those licenses properly, if we're overpaying or underpaying, we have more ability to do that. And that allows us then to look at modernization very differently. The DevSecOps is something that we had been pushing towards, and we had really were more DevOps, but not DevSecOps as much. But pulling out all of those capabilities from data centers and putting those into the hands of our vendor partners forced us to speed up DevSecOps and to be a little bit more bold and aggressive, because now our developers were required to handle more of the load and have more people working in conjunction with each other. And those are the kinds of things that have allowed healthcare.gov to get to a point now where it's really an anomaly when we have significant downtime during an open enrollment. And we know for the first 3 or 4 years, that was a common thing that happened, but it's really changed over the last few years. There's a lot of great folks over there working hard. They've still got a lot of work to do in the journey to maturity and the general journey to modernization. But the culture has changed and the mindset has changed, and they're moving forward. And that's one of the many, I think, success stories that CMS needs to share.
Yeah, I wonder, how would you rank the importance of culture, people, process, and tools in driving this change?
Well, for me, it would be number one. I say all the time when I'm talking about data and data analytics and modernization that my organization, we don't have a technology problem. We have a culture problem that is causing technology issues. And I don't think that is unique to CMS. I think that is across the entire federal government. Where you have people that have been in the organization for 30 days and some that have been there for 45 years. And, as Jess pointed out with USDS up front, they're kind of come in intentionally to be disruptors. And those disruptors help move the culture. But when you're in an organization that is highly distributed and lots of people with lots of problems and their own budgets, that causes challenges in trying to look at a problem from an enterprise point of view. And so we're constantly working the culture piece of this, because that soft skill piece of changing technology is as important, if not more important, than the actual technology is.
Yeah, I would agree. Though I might frame it as, I think, because people, for me, drive culture. You can try and kind of advocate for a certain culture, but if the people don't fully embrace it, if they aren't empowered to change the culture when they see an issue, for me, people are the biggest part. And so I mentioned before, we have found great allies and people who are hungry for change. And one of our core values is hire and empower great people at USDS. There are so many great people in government, and we actively work to find ways that they can achieve the visions. There's rarely, USDS rarely has an idea that someone else hasn't been struggling to get realized for a very long time. And we just introduce new tools to allow them to actualize that. And so the more you can kind of focus and build up the good workforce, the better.
Yeah, so, if the focus is on problem solving and not technology refresh, what new approaches do you think we need to help us solve real problems?
So Jess, I've gone first every time. Do you want to jump in?
I would say, I guess, a few different things. I think, and this is kind of present in my previous answer, is empowering people to ask questions. I think there's a tendency in government to kind of defer to, this is the way it's always been done before, and so this is how we're going to continue doing it. But if people are focused on the right North Star, which, at CMS is providing the best possible service for providers and beneficiaries, then I think that opens up a lot more space to question the way things are done and to pursue and try new things. And if we can work to give people more air cover so that they're not going to be punished for asking those questions or for trying new things, I think that would open up a whole new world.
Yeah, I agree. And like Jess, my answer really has been buried in many of the answers that I've already provided. I think we need to double down on problem solving, that we need to focus on where are there problems that we can indeed solve and not just simply do work for the sake of doing work and not, well, everyone else is moving to the cloud, so let's move to the cloud. What problem are we solving as a result of moving to the cloud? And we need to be very focused on our stakeholders and we need to always have a focus on the business and not just on the technical. And I'm one of those black and white thinkers because I'm an IT person. It's like, well, you got a problem? I can build you something to solve that problem. And what we really need to do is look at the process and look at the business challenge and then come together with people who have skill sets in other areas outside of technology and then come to a common shared view of what a future could look like and how we can go address that. I do believe that leadership is extremely important, and we're fortunate that we have leaders at CMS that see this challenge and are bringing in the right people and are saying the right things and forcing challenging discussions. I think we also need to be willing to embrace risk and see risk for what it is. First of all, understand it, and then secondly, work to mitigate it and be prepared for whatever negative may come as a result of that risk. And that way, when a problem happens, we're not overly chastising someone for that problem because we knew that might happen. And we want to create a culture where people are willing to take managed risk to make us better as an organization.
Yeah. Thank you. I know we're coming up to time, but I just wanted to get at least another question in. CMS is providing a lot of back-end services to state and local government through the different Medicare type programs out there. I guess this is to Jess. How does user-centered design help build out new back-end systems that are supporting an end user that may be 2 or 3 layers away from the environment that you're working in?
Yeah, I think user-centered design can help you understand and map and connect different people's motivations and needs. For the project I'm working on, the Medicare Payment System Modernization, we have these direct users. They're the people who have their hands on the keyboards of these systems. And they have a ton of pain points, right? They're using green screens today. The systems are very slow when they leverage screen scraping. So when I first joined, CMS was advocating for user-centered design. And so they're like, these are our users. This is who we need to talk to. I'm like, great. That's the first step. But these people who are using the systems are using them on behalf of CMS to provide a service to clinicians, to doctors, who are providing a service to beneficiaries. Let's talk about how, what pains we're addressing have that impact and work it all the way out. And then also talk about how it impacts the rest of the business functions at CMS. You know, it drives the data that's in these systems, drives fraud, waste, and abuse, you know, program integrity. It drives these beneficiary facing systems. You know, this data can feed mymedicare.gov or Blue Button or data at the point of care, which impacts care coordination and understanding of your benefits. And if we're not actively seeking out all of these people who are using the data that comes from these systems, we can't understand how to best support all of these different people, and we know that they're going to be impacted. And so human-centered design kind of gives you the tools to map that out and think through that. And yeah, I think that's crucial for any of these back-end type problems.
So with a focus on problem solving, Bobby, where do you see technology playing a part at CMS over the next 12 months, say?
Well, we are a heavy technology player, and we spend billions of dollars a year on technology, as many of your audience members know. At the end of the day, this kind of goes back to what Jessica was just talking about on the human-centered design point. Technology should play a role when technology should play a role. It should not simply be the role, and that we have to work very closely with USDS and our partners and stakeholders. And our CIO, Rajiv Upal, is very focused on human-centered design and wants us to think of that right up front in all of our projects. So we're going to continue to do that. We're going to continue to figure out ways to solve problems for the organization.
Okay, awesome. Well, I think I'm out of time. I'm going to have to thank you very much for taking part in this session. I had a bunch more questions to ask, and maybe we can have a follow-on conversation another time. But Mike Hoffman, passing the session and the torch over to you.
All right. Well, thank you very much, Andrew. Wonderful panel. Thank you very much to Jessica and Colonel Saxon as well. Great to have the CMS perspective there. So thank you very much. So that does, as Andrew said, that wraps us up for this morning/afternoon's event, Digital Health Modernization. Be sure to check out the rest of our events coming up the rest of this year. Our next one is actually next week on October 7th. And it's going to be focused on infrastructure, foundations of the future. We have a really exciting lineup of speakers for that one as well. So make sure you register now for it. We'll also have our full list of virtual events for the rest of 2020, and I think in the next week or so we'll be able to announce our events for 2021 as well. I know our managing editor and director of events worked hard on that over the past few days to do that. So we're really excited to announce that to everybody here. So make sure everybody, if you can share online and social media some of your thoughts from the event, would be extremely helpful as well. So until next week, thanks again, and we look forward to seeing you soon.